Hi everyone, you're very welcome to the Camogie Association Self-Care Series. This is our second webinar of the series where we'll be looking at preventative screening. So this webinar will be delivered by Dr. Aoife Collins and Dr. Noirin Russell, and they're going to take us through the importance of screening as a key part of preventative health measures. We'll also have a small bit of a Q&A at the end. So for now, I'll pass you straight over to Dr. Collins to begin.
Thanks, Louise. Good evening, everyone, and thanks for joining. As Louise said, my name is Aoife Collins. I'm one of the Senior Health Promotion Officers with the National Screening Service, and I'm joined by Dr. Noirin Russell, the Clinical Director with Cervical Check. So this evening we're going to discuss the screening services, and Noirin is going to focus in more detail on the Cervical Check service. So just to give you an overview of what we're going to cover this evening, what is screening? So I'm going to go through with you what exactly screening is, the 4 national screening programs that we have. So I'm going to give you a little bit more detail on breast check, bowel screen and diabetic retinous screen, and Noirin is going to talk to you in more detail in relation to the cervical check program. So just to go through with you what screening is firstly, the purpose really of screening is to identify people who are healthy. So it's very important to remember that screening is only for people who don't have any signs, symptoms of concern. So we invite healthy people for a test to see whether they are at risk of a health condition or a health problem, so that early treatment or interventions can be offered. And this in turn will usually lead to better outcomes for people. So when we talk about screening, I often think about screening as being like a sieve process. So what we do is we invite a large number of people to go through a test, which is the sieve. Most people will actually go through that sieve because they won't have any condition or any concerns. Unfortunately, a few people will go through that sieve who should have been picked up in the sieve. And then also we will pick up people in that sieve who may need to go on to have further treatment. So it's very important to understand the benefits and limitations of screening. So again, if you think about the sieve, so screening may give you an indication that a condition is there before there are any symptoms. So again, screening is only for people who don't have any signs, symptoms or concerns. And screening may give you that indication that there's something there before the symptoms develop. If a condition is picked up at an early stage, usually the treatments are much less radical, and also the treatments are more likely to be curative. So there are the benefits of screening. And then when we look at the limitations of screening, we do know we can miss a number of conditions, and sometimes we can provide false reassurance to people. So you go back to the sieve and you think about the people who go through that sieve who actually did have a condition there and it wasn't picked up through screening. Also, screening can lead to unnecessary worry. So these are people who are caught in the sieve who we think may have a condition or need to be assessed in greater detail. And then it turns out they don't have that condition present. And then we can also diagnose people who actually may never go on to actually have a condition that will cause them harms or would have caused them any issues in the long term. So to just take an example of the sieve again, for instance, for breast screening, if we were to invite 1,000 women for breast screening, so these are women aged 50 to 69, if we invite 1,000 of those women, actually only 7 of those women will have a breast cancer. 2 of those women, unfortunately, we will be missed and will go through the sieve. And we will also pick up a large cohort of women, about 40 women in that sieve, who again will need further assessment, and only 7 of those 40 women will actually have breast cancer. So again, it's really important to understand that there are limitations to screening. We're not going to pick up everything. Sometimes we will give people false reassurance, and sometimes we'll pick up conditions that would actually may never have progressed into anything more serious. It's really important for everyone to make decisions around their own health and look at the potential harms and the potential benefits of screening. We know what screening will offer a route to diagnosis and treatment for the whole population at an early stage, but sometimes, we will miss people and we will cause harm to some people. It's really important as well just to know that our screening programs all operate to the best international standards. So we have very strict criteria that we need to follow in relation to all of our screening programs. So what 4 population-based screening programs do we have here in Ireland? So as I said earlier, I'm going to focus on breast check, bowel screen and diabetic retina screen. And because many of you involved with Colposcopy Association would be eligible for cervical check or may become eligible for cervical check soon, Noirin is going to focus on that in more detail. So if you're aged between 25 to 29, you're invited for cervical check every 3 years. If you're aged between 30 to 65, you're invited to cervical check every 5 years. And Noirin, as I said, is going to go through that whole process in more detail with you and what we do in cervical screening. And for the other programs, I'm going to cover those ones. And again, just so you realise that we have registers for each of our programs. So each program has an individual register. Our registers have our name, the name, address and date of birth of eligible people for the screening programs. So for breast check, we have women aged between 50 to 69 on our register. We have for bowel screen is people aged 60 to 69. For diabetic retina screen, it's all people with type 1 and type 2 diabetes aged 12 plus who have diabetes are on the register. And for cervical screening, 25 to 29 if you're every 3 years, if you're it's for all women aged between 25 to 65 are on our register. So all of these can be checked and updated online or using our free phone number 1-800-454555. So I think what's really important, the message to take away this evening is while we have our register set up, we get our information from the General Medical Services, the Department of Social Protection. So if people have a PPS number, they should be on our registers. However, some people are not on our registers, so it's very important that everyone checks that they're on the register and also that we have the right information for people. So we send letters for all of our 4 programs inviting people for screening. So if we don't have the correct information, so if we don't have somebody's correct address, you may not be receiving letters from the program. So if you're eligible for our programs, it's really important just to check we have your details and that we have all the correct details. And all that can be checked, as I said, by going online or using our free phone number 1-800-454555. Okay, so just to give you a brief overview of breast check. The aim of our breast check service is to detect breast cancer at its earliest possible stage when it is easier to treat. So again, it's for women who have no symptoms or concerns. They will go to the breast check service. It's for women aged between 50 to 69 and they're invited every 2 years. Mammograms are offered in local communities at 4 static and 21 mobile units. So we invite women either to a main static unit, so we have 2 in Dublin and we have 1 in Cork and 1 in Galway, or we have 21 mobile units. So those mobile units are scattered all around the country, and we have our mobile units to ensure that it's more accessible for people to be able to avail of their mammogram. And so you can see from the picture at the side, this is what a mammogram looks like. This is what the machine looks like. The breast is placed horizontally, like in this picture, in between 2 plates. The plate comes down on the breast, and that's done to flatten out the breast to ensure we get the best possible picture, that we lower the dose of radiation, and that we get the best possible view of the breast. We also take a vertical view, so this is where a lady would stand to the side and get a view of the side of the breast as well. So, you know, it's very important, I think, for people to know what a mammogram entails, that it can be painful for some women, and it's very important that we get our best possible view, and sometimes we do. That is why the compression is required. So mammograms are less reliable in women under 50. There's a few reasons for this. We know that the composition of breasts in premenopausal women is different to women postmenopause, and it's more difficult to view cancers on women under 50 using a mammogram. We also know that the prevalence of breast cancer is higher in women aged between 50 to 69 years. And while we do have a lot of breast cancers in women under 50, it's much more prevalent in women over 50. We also now know that the benefits do outweigh the harms in screening women aged between 50 to 69, and we are reducing mortality in women in that age group who may get breast cancer. For the women under 50, the benefits at the moment from the evidence would be lower and the harms seem to be greater. We can end up with a lot of overdiagnosis and overtreatment of women, and also an increased amount of radiation dose to women. And we are doing ongoing research in this area, and there are considerations being considered by the National Screening Advisory Committee, just to look at, the evidence around increasing or decreasing the age for breast screening. What's really important though is that if any person at any age has any concerns about their breasts, they should not wait for screening. They should contact their GP to follow up straight away. So you should never wait. We would often get people who would contact us through our email, our free phone number, our info at details, saying that they have a concern, they have a pain in their breast, or they have a lump, and they want to know when they're due their breast check appointment. But what's really important message is that you should never wait for your breast check appointment. You should attend your GP if you have any concerns or symptoms, and that's for women of any age. Now, the next program we have is Bowel Screen. Bowel Screen offers free home bowel screening for people aged between 60 to 69, and this is every 2 years. The test itself, it's different to the others in that it's something that's done at home. It's a kit that's sent out to the home. And what we do with that kit is we ask people to do a stool sample or a poo sample in the toilet. And if you look there at the images to the right of the slide, you can see that you do your stool sample in the toilet. You then take the little stick that's in the vial in picture number 2. You scrape that stick along your stool sample. You close the vial and you send it back. And there's a stamped addressed envelope with your that comes with the vial in a pack, and you send that back. What happens then is that sample is analysed in the lab, and what the lab are doing is they're looking for blood that's in the stool that you can't see. So if you're seeing blood in your stool, you would need to go to your GP and discuss that with your GP. What we're doing with this screening is we're looking for blood that's not visible to the human eye. If we do detect blood in that sample, you will be referred for further tests, which is a colonoscopy, and that's looking at your bowel in more detail. And again, as I said, if you have any symptoms at any time, regardless of your age, you would need to go to your GP. And then the third program we have is Diabetic Retinous Screen. And this, I guess, is different to our other programs in that somebody already has a diagnosed condition, they are a diabetic, and secondly, it's not related to cancer services. So it works similar in that we invite people by letter, you get your appointment, you attend for your test, and it's for all diabetics, type 1 and type 2, who are aged between 12 and over. And just diabetic retinopathy is a complication of diabetes, and what happens is there's damage caused to the back of the eye, which actually, if it goes undetected, can actually result in damage to the person's sight and blindness in the long term. So what we're doing with diabetic retinopathy screening is we're looking for any changes in the back of the eye. We use special digital photography at over 100 screening clinics across the country. So nobody should be traveling more than 20 kilometers for their appointment. You do need to get drops put in your eye for the test, so your pupils are dilated. You do need somebody to bring you to your appointment because you can't drive afterwards because your vision is blurred after getting the drops into your eyes. So if a level of retinopathy is found, then you're referred on for diagnosis and treatment to a treatment centre. So we have 7 treatment centres across the country for anyone who's picked up to the Diabetic Retina Screen programme. Okay, so just in relation to if you need to contact us, we have an info at and we have a free phone number for all of our programs. So the free phone number, if you dial the free phone number, you'll actually be able to talk to somebody about each of the programs separately if you need to talk, you know, so if you're eligible for 2 or 3 or 4 of the programs, you can actually ring the free phone number and somebody can check anything that on the information line, can check any information that you need to get on that one call. And then we also have our specific direct email addresses for the 4 programs, and then also for the National Screening Service. So I suppose just to finish up, there are just a few things I'd like people to take away with them for this evening. Is just firstly to understand that we offer screening, so we are only inviting people in a certain age cohort for screening who have no signs, symptoms or concerns. If you do have any signs, symptoms of concerns of anything in relation to any of the 4 programs here, you need to be contacting your GP. Secondly, it's really important to check our registers, to check that we have all the correct information on our registers for you and that you're on the register. And some people this evening may not be actually eligible for our screening programs or may be eligible for 1 or 2 of them. It's really important though for you to consider family members, friends, colleagues who may be eligible for our screening programs, and to just let them know that we have our registers, just to check that they're on the registers, and if they're not on the registers, to put themselves up on the registers, and also to update their information, because we ideally would like 100% attendance for our screening programs. We have different levels of uptakes for our 4 programs, and some people, as part of my work, I suppose I'm out with the public a lot and I meet a lot of people and they'll say, I never got a letter. So sometimes it is the case that they're not on the register, or we just don't have the correct information for them. So it's really important as well just to make sure that people check they're on the register. So I'm going to now pass you over to Noirin, and I'm going to stop sharing there and let Noirin. So Noirin is going to talk about cervical check and cervical screening.
Thanks very much. I'm just going to throw it into presentation mode there. So thanks very much. Thanks for that sterling run through the programs, Aoife. As you mentioned, I'm going to focus a little bit on cervical check, but before I get going, I just want to say thank you very much to the Camogie Association. I have absolutely zero skills in this zone, but I am so proud of my daughter who can run around with her slitter and do wonderful things. And she said I had to mention her in the talk when I said I was, so nothing else I did mattered, but when I said I was talking to the Camogie Association, she said, oh, well, you have to talk about me. And I will also declare, because I'm going to be talking about counties later on, so like every true Cork person, I'll declare that I'm from Cork, because you need to know that if you're going to listen to my talk. Excellent. So I'm going to take you through HPV cervical screening. So why do we change from smear tests to HPV screening? I want to talk to you a bit about symptoms of cervical cancer. So Aoife mentioned it. Screenings for well people with no symptoms. If you have symptoms, you need to go to a different zone of the healthcare system, diagnostics. But if you're well, you should attend for screening. I want to talk to you about colposcopy. Often that word is it gets confused with colonoscopy. So colposcopy is a further detailed examination of your cervix, and I'll chat to you about why that might be necessary. A little bit about who needs more screening, and then some figures. Everyone loves a bit of data. What does cervical screening mean for the Irish population, and just give you some data on that. So what happens during a cervical screening test? Many of you will be familiar. So sample is collected by either your GP or the practice nurse, who does the majority of screening in the country. The sample is sent off to the laboratory and tested for the HPV virus. Really, the whole thing takes less than 5 minutes. It's mildly embarrassing, mildly uncomfortable, but so important to do. If at the lab HPV is found, that's the human papillomavirus, the same sample is checked for abnormal cells. Okay. If HPV is not found, the cells are not checked, because the risk of you developing cell changes is incredibly low, and any abnormalities that do occur in between there and your next screen are likely to return to normal if there's no HPV there present niggling at them. So I thought would be interesting because women sometimes ask me interesting questions about like what do their ovaries look like when I'm doing a screening test, and it's important to, I suppose, to be clear about what we can see and what we can't see. When the sample taker, smear taker, is looking at your cervix and taking that sample, what we can see is probably the lower 1/3 of the cervix here, this bit. We don't see the whole cervical canal. We don't see what's happening up here. We don't see the uterus, and we don't see the fallopian tubes or the ovaries. So that's it. It's kind of the vaginal wall and the lower part of the cervix. It's not a full gynecological assessment, which is why if you have symptoms, you have irregular bleeding, what we can say with a smear test is, well, there's no abnormal cells down here in the bottom of your cervix, but it's not a thorough, full-on gynecological assessment. And that's why if you do have symptoms, it's important to go and get those looked at. So this is a lovely kind of graphic, I suppose, for why we change. So for every 1,000 women who have a cervical screening test, 20 will have cell changes, and they're the 20 we're trying to find. The old smear test would have picked up around 15 out of the 20, whereas the new test, testing with HPV, actually picks up 18 out of the 20 women who have abnormal cell changes. That's, it's a great success story. It's much better. It's 75%, has gone up to 90% detection. But unfortunately, as with all screening tests, it will not detect every woman with abnormal cells. And that's why 2 out of 20 will not be picked up. They may go on to develop cancer. And that's always why we give you the message about, look, if you get symptoms, don't rely on the previous normal screening test. You do need to get checked out. So what happens is if a woman tests positive for any of the 14 high-risk types of HPV, then the cells are examined. A negative HPV test shows that your risk of developing abnormal cells in the next 3 to 5 years is incredibly low. And a positive HPV test shows that means that you're at higher risk of getting abnormal cells, but it doesn't mean that cancer is present. And that's a really important message to get across, because women can get a bit of a fright when they get that result saying you've got HPV. If you have 2 positive HPV tests, you are referred onwards to colposcopy, even if there's no abnormal cells seen. So again, don't worry, that's around 1 in 20 women will be referred onwards for colposcopy. Sometimes it's because of abnormal cells, and sometimes it's just because you've had 2 HPV positive results. So HPV is very common. It passes through the skin, through skin-to-skin genital contact. Most people will get HPV infection at some time in their lives. That's the reality. Most people will also clear the virus through their system in 12 to 18 months, and that's great. For those people who don't clear the virus, and if it stays around for over 10 to 15 years, persistent HPV infection, it can cause changes in the cells of the cervix that can lead to cancer. But it's a really slow growing thing, 10 to 15 years before those abnormal cells turn into cancer. Now, it's really important. We've got a few questions on this. Even if you've had HPV vaccination, it's still important to attend for screening, because you've been vaccinated against some types of HPV, but you might still have other types of HPV that could cause your cells to become abnormal. These cells on the neck of the womb can become abnormal, develop precancerous features. That's because HPV, when it's present, that persistent HPV infection, it stops the cells from repairing themselves. So cells change all the time in our bodies. They repair, they change, they become abnormal, and then they repair. It's the HPV infection that stops that happening. Most cervical cancers are squamous cell carcinomas, and 99% of squamous cell carcinomas are associated with HPV. Now, there are other types of cancers or cervical cancers on the neck of the womb. And unfortunately, screening, one of the types is adenocarcinomas. And unfortunately, screening is less likely to detect these. And that's why, again, I'm going to come back to the same thing over and over again. If you get any funny bleeding or any abnormal symptoms, you do still need to go and have a checkup with your doctor. Don't rely on the fact you've had a clear test. So the symptoms of cervical cancer, I've mentioned them a few times, but I might spell them out if that's okay. So the most common symptom of cervical cancer is irregular vaginal bleeding, especially bleeding in between periods or after sex. Sometimes it can be spotting or just unusual discharge after sex, but it's kind of reddish brown. So if you encounter these symptoms, or if you have any bleeding after you've gone through the menopause, these are not normal. You need to see your GP, because these could be something of concern. Now, results, when you get your result letter from Cervical Check, usually you get a letter to you and a copy to your GP. The results should be back within 6 to 8 weeks. We're working really hard on this, and we're trying to get them back within 4 weeks, because we know it's quite anxious when you're waiting for your result. There's kind of 4 options. The letter might say HPV not found, and then you'll be advised to have a test in 3 or 5 years. HPV found but no abnormal cells, you'll be told to have it because the HPV have a repeat test in 12 months. HPV with abnormal cells, you'll be referred onwards for colposcopy or an inadequate sample. And that's why there's not enough cells to be examined, and then you'll be asked to have a repeat test in around 3 months. So it is expected at the time of screening that 1 in 8 women in Ireland are HPV positive. So that might be something you're well aware of, might be a bit of a shock. But we get a lot of questions at the info line. People are a bit surprised because we've changed to HPV screening. It might be the first time they've heard that they've got HPV infection, but it's really common. 12% of the population, 1 in 8 women are HPV positive. The vast majority, especially of younger women, will clear it out of their system. So it's a very common infection. 1 in 20 women will have low-grade abnormalities, and 1 in 100 women will have high-grade abnormalities. And most women have their screening test, they get a reassuring result, everything's fine. But 1 in 20 women will be referred onwards to a colposcopy clinic, which is a kind of a specialized gynae clinic, usually located in one of 15 kind of sites on site with the hospitals around the country. Now, even of the women who are referred, so I said 95% of women are reassured, 5% of women who are referred to colposcopy. The vast majority of women referred to colposcopy for assessment do not have cervical cancer, and actually over 80% of them don't even need any further any treatment or anything. It turns out that there's nothing major going on. So referral to colposcopy, as I said, will occur if you've had changes on the cells, abnormal cells, or if you have 2 subsequent HPV positive results. Colposcopy for you kind of feels like a smear test. The colposcope is very similar. So the speculum is the same as the GP or the practice nurse uses to take the screening sample. But what we use in the colposcopy clinic, we use a colposcope, which is like a kind of a microscope, and we can really magnify the cervix and look for any abnormalities on it. Most women, over 80%, will be told there's no abnormal cells, everything looks fine, and they'll be sent back out to their GP. Some women will need a biopsy or a treatment, and this is usually performed under local anaesthetic in the clinic, and is very, very, very tolerable. We get a few questions about, I'd like more screening, or why is it, gone down to 3 or 5 years? And I suppose there are some women who need more screening, but there's a lot. But I'm going to tell you a few stories about that. It mightn't be quite who you think. So one of the things we've noticed in our data, and this comes up as far as March last year, is that as women get older, they're less likely to attend. So look down here, the 25 to 29-year-olds, nearly 90% of the population, or eligible population, are attending for their screening tests. It gets a little bit lower in 30 to 34-year-olds. I suspect that's due to a lot of women in that age group having children. Back up to over 80% here, over 80% here, over 80% here. But then look at this. When women become menopausal into their 50s, they just think screening isn't for them anymore, and it's just less likely. Maybe it's a bit more uncomfortable, and they think, oh, sure, I really don't need to go. And you can see that less women attend. It goes down to kind of 70%. And then by the time we get to 60, it's down to 60%. So I suppose if there's anybody listening to that tonight who's in between 50 and 65, or your mom or your aunt or friends, that just encourage that age group. We do really want our 50 to 65-year-olds to still attend for screening, because it does reduce their risk of developing cervical cancer later in life. This is an interesting one. What we want, we're aiming for, look, I'd love it if 100% of eligible women came for screening, but the programme aim is we're trying to get 80% of the eligible population to attend. And what we've noticed is that the majority of the time, there's a lot of counties, you can see the dark blue here is those where the counties where over 80% of women are attending for screening. The paler blue then is the 75 to 79%. But there are 6 counties, right, where less than 75% of women who are eligible are attending for screening. So these are women in the 25 to 65 age group. They're eligible for screening, and 1 in 4 women who's eligible is not attending. And we'd love to know more about why that is. For you to know, because it's, I think this is really, it's great. It's an All Ireland organisation, and I'd love to know if you have any insights why women in Dublin, Monaghan, Kilkenny, Clare, Roscommon, and Laois are less likely to attend for screening, and what do we need to do as a kind of an organisation to improve that. So another group where we know that they're less likely to attend for screening is migrant communities. So people where English is not their first language. And we've been working really hard with Translate Ireland, and we've produced a whole series of multilingual videos. These are a really great resource, because there's no doubt about it. Hearing a woman speak about cervical screening in your own language, women find that very reassuring, and it's certainly it's an initiative we're very proud of. And Translate Ireland have recently won a Healthcare Ireland award. So look, it's a great it's just trying to think of what are the barriers that make people less likely to attend for screening and trying to address them. And one of the questions we get asked a lot is, why do you not screen women under 25? And I suppose, you know, people think, oh, it's to do with sexual activity, and maybe we don't realize that women are sexually active under 25. Not at all. That's not why screening begins at 25. It begins at 25 because screening is a balance between benefits and harms. And actually, the potential to do harm for women aged less than 25 outweighs the potential to do good. What do I mean by that? Abnormal cells in this age group. First of all, HPV infection in this age group is incredibly common. Abnormal cells in this age group is very, very common as well. But the vast majority of these cells will go back to normal once the HPV leaves and once the infection is cleared. And actually, if we identify and treat abnormal cells in this age group, we can cause cervical damage, and that, you know, could cause an increased risk of late miscarriage and preterm birth later on down the road. It's really something to be avoided. So if a woman under 25 has symptoms, she doesn't need screening. What she should do is attend her GP, because those symptoms need to be investigated. But screening under the age of 25 for women between 20 and 25 has the potential to do more harm than good. And I'm going to finish up by just giving you a few statistics, a few numbers. I love the old numbers. Every year in Ireland, around between 270,000 and 280,000 women attend for screening every year. As I said, 90% who attend will have a normal result. And around 15,000 women every year are referred onwards for a colposcopy. In the colposcopy, the majority of women don't need any treatment, but around 6,500 women every year are treated for CIN. Out of that 6,000, again, around 150 women per annum will be diagnosed with cervical cancer in colposcopy. That is, by virtue of attending colposcopy, through screening, they get diagnosed with cervical cancer. So you can see it's a very important number, and of course we're trying to find those women, but actually the vast majority of women who are screened do not have cervical cancer. Now, it's important to note, nearly the same number, again, between 100 and 150 women will be diagnosed with cervical cancer after they go to their GP with symptoms. So yes, if you want to get rid of, you know, if we want to eradicate cervical cancer in Ireland, we need to have rapid access for women to gynae clinics, as well as getting everybody screened. And that's why it's everything in healthcare is a balance. So screening, we hear a lot about screening when we hear about cancer care, but actually 24,000 Irish people per annum are diagnosed with cancer. Of that, around 1,500 are diagnosed with cancer via screening programs. As I said, around 150 of those who are women diagnosed with cervical cancer. But 22,500 people are diagnosed with cancer when they attend their doctor with symptoms. And that's why it's so important to advocate for access for everybody in the country. Access to GPs, access to specialists, access to diagnostic tests like CT, MRI, ultrasound, because that's where that access, and it's particularly challenging, you know, since COVID and all of the stress and the access problems that the COVID pandemic brings. But it's really important. We need to invest in having our GPs and having our specialists, and we need to have access to tests. So takeaway messages: screening with HPV is better than screening with smear tests. Screening reduces the risk of cervical cancer, but won't detect all cancers. Women and people with a cervix must still attend for screening, even if they've had the HPV vaccination. Screening does more harm than good under the age of 25. It's important to know the symptoms of cervical cancer and attend your GP, even if you've had a recent negative screening test, or even if you're under 25, if you have any of those symptoms, irregular bleeding, bleeding after sex, bleeding after or in between periods, you need to attend your GP. Women and people with a cervix between 50 and 65 still need cervical screening, still reduces your risk. We need to address this geographical variation in screening, and every year 24,000 people are diagnosed annually with cancer, and they need access to diagnostic tests. Screening picks up around 1,500, but most people present with symptoms. So you can find out more about Cervical Check by emailing info@cervicalcheck.ie or free phone 1-800 45 45 55. I'm delighted to take any questions. Thank you very much.
Thanks, Noirin. And Aoife, that was brilliant. We did have some questions coming in the registration. I think you've probably answered most of them, but we'll go through a couple anyway. First one was, why do I have to come for screening when I have the HPV vaccine?
Excellent. Will I take that one, Aoife?
Yeah, that's definitely you, Noirin.
Yeah, so the vaccine, it doesn't protect against all types of HPV. So there are we've had different types of vaccines at different times in our vaccination program. We started off, I think, with four HPV strains being covered. We've moved on to 9 HPV strains being covered, but not all types of HPV are vaccinated against. So you could have the vaccine, but you could still have HPV and you could still get abnormal cells. So you can't rely on that on its own.
Okay, perfect. So when your screenings come along, make sure we go for them.
Yeah, exactly.
What if I have abnormal cells and you're just testing me for the HPV virus, and those cells aren't picked up on? What is, I suppose, the best advice there?
Yeah, so we get asked that question a lot since we've changed to the HPV program. And I guess it's about, if you can imagine that the real problem here is the HPV infection, not the abnormal cells. So HPV, if you develop abnormal cells, which will happen, all of our cells in our body change all the time. And if a woman develops abnormal cells, if she doesn't have HPV, those abnormal cells will sort themselves out and will go back to normal. That's their natural history. Where the problem is if you develop abnormal cells in the presence of a HPV infection that just persists and persists and persists, it's the HPV stops the body's normal response of turning the cells back to normal. What the HPV does is it stops your body being able to normalize the cells, and it makes the cells stay abnormal. So without the HPV, your cells will change, go back to normal by themselves. But if it's in that combination, if you have the combination of abnormal cells and a persistent HPV infection, that's where the risk is. And that's why we know that by testing with HPV first, that's actually a better predictor of those people who are going to go on and develop problems.
Okay, brilliant. We had a few questions around symptoms. I think you've gone through the symptoms already, but just in general, what are the symptoms of cervical cancer that we should be looking out for?
So the biggest ones really are postcoital bleeding. So bleeding after sex, or this kind of random bleeding in between periods. Anything new is important. So if you develop a new symptom and you know, God, that's not my normal, like that bleeding between periods, or kind of a brownie vaginal discharge. Sometimes women say, oh, well, it wasn't really a bleed, it was more of a discharge. But if you have a kind of a abnormal discharge in between periods, or abnormal bleeding, or bleeding after intercourse, they're the big ones really that I would say, look, you need to attend your GP and get checked out.
Okay, brilliant. And last question that came in, if anybody is anxious about the screening, I suppose it's quite vulnerable coming in for mostly the breast screening and the cervical screening. What advice would you have for anybody feeling anxious?
If I'm going to give that one to you, how would you? What would you say?
Yeah, well, I guess like we've done a lot of like looking at around, I suppose it's about being informed and having the information before you attend. And we do know, we've done a lot of surveys in the last few years, and we do know that the majority of people get their information actually from their GP or their practice nurse. So I think it's really important, if there's any concerns, that you contact your GP or your practice nurse, or prior to screening, especially I guess like or for any of our screening programs, to talk to the health professional who's actually going to be doing the test. And also, I mean, the more informed somebody is, the more reassured they could be. So it's really important, to look at trusted sources of information. So the HSE website gives a huge amount of information. Just to be careful again where you get your information from, and just to make sure it's a trusted source. But and I guess then if you are, I suppose, apprehensive, or when you come for your appointment, to let that person know, the person doing that test. That's really important as well. Because I mean, I'm sure, Noirin, from all your years of experience as well, you meet an awful lot of anxious people who come for any kind of test or screening, or so it is just around letting that person know as well, and they will to talk, say to the person, look, I'm a bit anxious, I'm a bit worried, or and also check and get the information prior to attending as well, and also contact our free phone number for more information, email us in, and I think it's just important, I guess, to have an understanding around the test, what's coming, what the test will entail. And I definitely, people do trust the health professionals person that they go to for their information. So but again, very happy for any queries to come in through our services as well, and to answer anything that comes in.
I think something that can help as well is maybe just bringing someone with you. So kind of saying, well, look, it's okay. I do feel a bit nervous, and don't be a bit embarrassed about feeling nervous or anxious. I think that's a really normal reaction, especially going for a smear test. So clear a bit of space beforehand. So don't come straight from work, because I think that's really stressful. So give yourself a little space beforehand, but much more importantly, give you a little bit of space afterwards. I often say to women, like, especially after colposcopy, now make sure you go and have a cup of coffee or a cup of tea, or just kind of congratulate yourself that you did this thing that you really didn't want to do, but now you've done it. Because I think that's important. And I think that helps, just the little bit of space beforehand, and bringing someone with you. And even if they're just like outside in the car, just to know that they're there, and then you're going to go for coffee with them, it just makes it kind of adds something nice to something that you've kind of been not really looking forward to. And it probably makes you a bit more likely to do it as well, because they kind of say, oh, well, I said I'd come with you, and we go for coffee afterwards. So it gives you that extra little bit of a prod.
That's brilliant. And I think all the information that you've both gone through tonight will, you know, put a lot of people's mind at ease by just having that information and knowing what to expect. So thank you both very much, and on behalf of the Camogie Association for contributing to our series. We really appreciate it, so thank you very much, and thanks to everybody that's been tuning in. We will have all episodes of our series up on our Camogie Association YouTube channel, so you'll catch them all there. Thank you very much.
Thanks a lot.
Thanks, everyone.
Cheers. Bye-bye.
Bye.